An amiable welcome to everyone. This is your Allied Lecdem channel to enhance your understanding. Today's topic is about anesthesia instruments and equipments, rails, tube and bougie. Previous videos are available in our OTAT playlist. Do check it out for your better understanding. Let's get into the topic. Rails tube or nasogastric tube. It is an insertion of a tube into the esophagus and stomach through the nose. Gastrointestinal intubation deals with the inserting of a rubber or plastic tube into the stomach, duodenum, or small intestine. Types of tubes: short tubes, passed through the nose into the stomach. Medium tubes, tubes are passed through the nose to the duodenum and the jejunum, used for feeding. Long tubes, passed through the nose, through the esophagus and stomach into the intestine, used for decompression of the intestine. This is the position of the nasogastric tube after insertion. Sizes of nasogastric tubes. Nasogastric tubes comes in various sizes: 8, 10, 12, 14, 16 and 18 French. Parts of the tube: tip, drainage port or lateral eyes, radio opacity, radio opaque line or strip, body markings: 50 cm stomach, 60 cm pylorus, 70 cm duodenum and the base. Sizes: for adult, 16 to 18 French tubes are used. Pediatric: in pediatric patients, the correct tube size varies with the patient's age. Indications of GI intubation: to decompress the stomach and remove gas and liquids, to lavage the stomach and remove ingested toxins, to administer medications and feeds. As part of the management of an obstruction, as part of the management of Harmut emesis, that is vomiting blood, to aspirate gastric contents for analysis. Contraindications: gastric surgery, ulcers, transesophageal fistula, esophageal surgery, polyps in nose, recent nasal surgery, facial surgery, deviated nasal septum, patient on anticoagulant therapy. Who needs a nasogastric tube? Surgical patients, ventilated patients, neuromuscular impairment, patients who are unable to maintain adequate oral intake to meet metabolic nutritional demands. Intubating the client with a NG tube. Assessment: assess patient's medical history, nosebleeds, nasal surgery, deviated nasal septum, anticoagulation therapy, GI history, assess the patient's gag reflex, assess the patient's mental health. Preliminary assessment: check doctor's order for any specific instruction, patient ability to follow instructions, general condition of the patient, articles available in the unit. Preparation of the patient and unit: explain the sequence of procedure, arrange the articles at the bedside, provide privacy, provide comfortable position, Fowler's position, place the Macintosh and towel across the chest, remove the dentures, give mouthwash and help him to clean the teeth, clean nostrils. Procedure: wash hands, put on clean gloves, lubricate the tube, hand the patient a glass of water, gently insert the tube through nostril to back of throat. Have the patient flex the head towards the chest after tube has passed through nasopharynx. Emphasize the need to mouth breathe and swallow during procedure. Swallowing facilitates the passage of tube through the oropharynx. When the tip of the tube reaches the carina, stop and listen for air exchange from the distal end of the tube. If air is heard, remove the tube. Do not force tube if resistance is met or client starts to cough, choke or become cyanotic. Stop advancing the tube and pull back. Secure the tube with tape. Methods to confirm NG tube in the stomach: aspirate. Attach the syringe to the end of the NG tube and aspirate small amount of gastric content. X-ray. Immerse distal end of the tube into the bowl of water and check for air bubbles. Auscultate. Attach syringe to free end of the tube. Place diaphragm of the stethoscope over the left hypochondrium. Inject 10 ml of air and auscultate abdomen for gushing sound. This is an X-ray showing the placement of NG tube. Bougie. Definition. The bougie is an adjunct for difficult endotracheal intubation. Indications. For directional control during routine or difficult endotracheal intubation when the laryngeal inlet cannot be completely seen. Precaution. Excessive force, passage beyond the carina, or blind introduction may result in soft tissue damage or may cause rupture of bronchus. The endotracheal tube should not be threaded over the introducer without the laryngoscope in place. Features. Single and sterile pack reduces the risk of cross-infection. High gloss, low friction outer surface improves tube glide over the bougie. Low point of pressure tip reduces the risk of accidental trauma. All available in 10 ch and 15 ch, suitable for use with all tubes from 4 mm to 10 mm IB. Also available in 5 ch for use with 2.5 mm ID tubes. Extra tip graduations allow for improved laryngeal inlet entry and exit guidance. Clear, highly visible outer packaging for ease of product identification in emergency situations. Barium tip for improved X-ray guidance. Procedure. A 15 French introducer should be used for endotracheal tubes size from 6 to 11. Lubricate introducer into the KY jelly. Perform laryngoscopy. If cords not visible, identify landmarks to aid intubation. Place introducer into the pharynx and directly into larynx. If necessary, bend the introducer to negotiate the corner. Correct placement may be confirmed by the detection of tracheal clicks and holdups of the bougie. No holdup indicates esophageal placement. Leave laryngoscope in place while assistant threads endotracheal tube over introducer into trachea. If tube sticks at the laryngeal inlet, a 90-degree counterclockwise rotation may help. Hold the tube firmly in place and gently withdraw the introducer. Remove laryngoscope and confirm the tube placement as usual. If preferred, the endotracheal tube may be placed over the introducer prior to intubation instead of using stillet. Pediatric consideration. A 10 French introducer should be used for endotracheal tube sizes 4 to 5.5. Tracheal tube intubation stillets. Single-use malleable intubation stillet for pre-forming tracheal tubes to the desired shape to facilitate intubation. Thank you.